So now guys, that we have completed the basic part of Squint, the theoretical part of Squint, so as to say, where we are able to understand what is Squint, how does Squint occur, what are the problems faced by a patient of Squint. We move on to the basic clinical part, the part that we should be learning actually in our postings, but alas we don't. That is how the medical educational system is built. So basically what we are talking about is the examination of a case of Squint. When a patient of Squint is standing in front of you, can you answer all the questions? Whether it is a case of tropia or phoria, what is the direction of deviation, what is the degree of deviation, whether any adaptation has occurred or not, whether it is a paralytic squint, whether it is a restrictive squint, whether it is a pseudoisotropia. So a lot of information needs to be answered in every case of Squint. So we are talking about the examination of Squint, or if I put it simply, the tests for Squint. Okay, everybody. So let's start. Number 1. The first thing that we always want to do in every case of Squint is examination of ocular movements in all directions of gaze. So now this is the important point here. We say in all directions of gaze. So what are the directions of gaze? How many directions of gaze are there? Even though I haven't told you the answer directly, guys, when we were discussing yoke muscles, if you think about it, I've actually told you the directions of gaze. Looking straight up, both eyes, sursumversion, deorsumversion, levo, dextro, elevation, depression. Do you get something in your head? Levoversion, dextroversion. Yes. So now if you calculate, there are how many directions of gaze, everybody? 9 directions of gaze. So now what are the directions of gaze, everybody? I will show you this image and then I will tell you. You can see 9 squares being made here. So when both my eyes are looking absolutely straight, everybody, I call it primary gaze. Okay. So the yellow box is the primary gaze. Yes, I understand. Now the plus sign, direct up, direct down, total left, total right, everybody. The green boxes, 1, 2, 3, and 4. These are which gazes, everybody? Green colored secondary gazes. And now the diagonal gazes, the dextro elevation, the levo elevation, the dextro depression, and the levo depression. These on which I have put a cross in purple boxes, everybody. These are my tertiary gazes, everybody. So I hope you understand through this diagram that there are 9 directions of gaze, 1 primary, 4 secondary, and 4 tertiary. So cross sign is tertiary, plus sign is secondary. Am I clear? Now, if I re-show you this diagram, this can be a diagram which tells you all the directions of gaze, all the directions, the names, and the muscles responsible, the yoke muscles responsible. So for example, everybody, if I see dextro elevation is purple color. That means a tertiary gaze. Dextro elevation means both eyes going up and to the right. So right going up and abduction. Elevation in abduction is an action of superior rectus, right superior rectus. Left eye elevation in adduction, a feature of inferior oblique. So dextro elevation is by right superior rectus and left inferior oblique, everybody. And this you will be able to see in this image. So basic complete revision of your yoke muscles along with the directions of gaze. Okay. So this is this example for you. Now the question which comes into my mind is, why am I examining the movements in all directions of gaze? So let's say the patient is not able to perform levoversion. Okay. Left eye levoversion is not being performed. As soon as I see that left eye levoversion is not being performed, I know that the muscle which must be having a problem is left lateral rectus. So basically through this movement, we are able to narrow down on the group of muscle or the name of the muscle which must be affected. And then we are able to work out on the causes of that paralysis or that muscle dysfunction in whichever form it may be. Am I absolutely clear? So first test always examination of directions of gaze, ocular movements. Okay. Now, moving on to the second test, everybody. The second test is assessment of visual acuity. Visual acuity is just a fancy word for vision. So you go to an ophthalmologist, you get tested your vision on Snellen's chart, everybody, yes. So we call it visual acuity. So we need to assess the visual acuity in every case of squint. Now again the question comes why? But before I answer that why, I will ask you what investigation is done to assess your visual acuity. See, Snellen's chart, okay. But let's say your vision is not 100% on Snellen's chart. Then how do you calculate the visual power? How do you calculate the power of spectacles? Okay. So I will say assessment of visual acuity is done through a series of tests in which we first measure visual acuity through Snellen's chart, but then we have to calculate the refractory power through an investigation which is known as retinoscopy or skiascopy. Okay, we calculate the refractory power. Okay, everybody, basic information. Now I am doing retinoscopy, I am doing Snellen's chart test in a case of squint. The question comes why? Why am I doing this, everybody? So why am I doing this? If I want to answer this question, everybody, I will write one statement. Uncorrected hypermetropia leads to esotropia. This simple line is an MCQ in itself and is asked very frequently. So please remember this line. I will make you understand this obviously, but first of all, please remember this line. Uncorrected hypermetropia leads to esotropia. Let us understand how is this relation relevant and how does it occur. Uncorrected hypermetropia. What is hypermetropia? Hypermetropia, if you don't know, guys, is loss of near vision. Okay. Now, as soon as there is loss of near vision, adaptation takes place. For near vision, there is an adaptation about which we've already read in the basic anatomy of the eye or when we were reading the classification of squint, everybody. What was that, everybody? There is a near reflex. Yes. So as soon as I lose my near vision in hypermetropia, my near reflex becomes overactive. What were the three parts of near reflex, everybody? Accommodation, convergence, and meiosis. That means whenever there is loss of near vision, it leads to over accommodation. Okay. No issue, guys. Over accommodation. But along with that, what will also occur? Over convergence. Now, what do you mean by convergence? I hope you remember convergence is two eyes converging. That means moving inwards as if trying to meet each other. So for normal near vision, let's say both my eyes move this much. But now there will be over convergence. That means both my eyes will be moving in this much. So because of over convergence, what will be visible to you? It will be visible as if both the eyes have deviated inward. And when both the eyeballs will look deviated inwards or would have deviated inwards in this case, you will call it what, everybody? Esotropia. So I hope you understand the cycle, everybody. If you have uncorrected hypermetropia, you have loss of near vision. Due to that, you have overactive near reflex, over accommodation, over convergence, and over convergence leads to inward deviation, which presents as esotropia to you. Do you understand this? Do you understand now why I need to assess your visual acuity when you come to me with a case of squint, everybody? This whole phenomena, everybody, if I box it out, this whole phenomena is known as accommodative squint. Accommodative squint because obviously it is associated with over accommodation. Now, the examiner asks you what is the treatment of accommodative squint. So accommodative squint is esotropic. It occurs due to uncorrected hypermetropia. Hypermetropia is a refractory error. So you need to at last treat the refractory error. So that means what should be the treatment, everybody? Treat the refractory error. Make the child wear a pair of spectacles. As soon as the child wear a pair of spectacles, the hypermetropia will be resolved. The near reflex will become normal. No over accommodation, no over convergence. Both the eyeballs will become straight. Esotropia will be resolved. Right, guys? So very simple assessment of visual acuity leads to a resolution of esotropia, everybody. So that is why it is important as a secondary step to do in every case of squint that comes to us. Am I clear, everybody? Yes. Moving on. Test number 3. Test number 3 is measurement of vergence. Measurement of vergence power. Now, what is vergence power? Everybody. Either both my eyeballs can move in the same direction, or both my eyeballs may be able to move in different directions. So when I say both my eyeballs move in the same direction, we call it version movement. I hope you remember. Version movement. Yes? Both the eyeballs looking up, both the eyeballs looking left, both the eyeballs looking right. But here we are talking about vergence. Vergence means both the eyeballs looking in different directions. Let me give you an example. Right eye, left eye. Right eye looking in, left eye looking in. Even though the eyeballs are looking in, everybody, right eye is looking in the left direction, left eye is looking in the right direction. This is called as convergence. Okay? Similarly, there is something called as divergence. Right eyeball looking towards the right side, left eye looking towards the left side. This is called as divergence. So I hope you understand the word vergence, convergence or divergence. Okay? This usually does not occur. As we know, both the eyeballs look in the same direction. But each extraocular muscle has a reserve fusional power, or I can say vergence power, which each muscle may use to keep fusion. Are you getting what I'm trying to say? As we just now read, diplopia can have an adaptation called fusion, everybody. We know that phoria is hidden but becomes manifest under conditions of stress. So what keeps the eyeballs straight during normal conditions? This extra power in extraocular muscle, this extra fusional vergence power, everybody. Yes? So when we are talking about a case of squint, we want to measure this quantum of reserve power. We want to measure how much is the power which can keep my squint from manifesting. Okay, everybody? Do you understand the basic fundamental of vergence power? Yes? So what are the tests, everybody, for measurement of vergence power? The first test, I will write down the name, is known as synoptophore test. The second test is called as the basic simple pencil test. This may have been done to you whenever you have gone to an ophthalmologist for measuring your convergence power, everybody. You hold the pencil, then you slowly bring it near. The examiner asks you at which point does it become hazy, everybody. Measures the near point of convergence, trying to measure the convergence, extra fusional power of your extraocular muscles, everybody. Okay? Then the third test which can be done is known as Livingstone gauge test, or the test which is usually done is known as RAF rule test. What is the full form of RAF? Royal Air Force. So this test was developed by the British Army during World War. British Army was known as Royal Air Force. So that is why the test is still named as RAF rule or RAF ruler test, whatever name we want to call it. Okay, everybody? Let's see the image of this instrument. This is what an RAF ruler looks like. Okay. These are the points which rest on your cheekbones. This target has some small text written on it, everybody, and this is movable up or down. Okay. The patient holds it in his or her hand, moves the target up and down to a point where diplopia occurs. Okay. So I can say target moved up and down up to a point where diplopia occurs. Okay. The point where diplopia occurs, that point is known as NPC, near point of convergence. If the vergence power is normal, the near point of convergence is usually less than 10 centimeter. Okay. If it is more than 10 centimeter, that means the vergence power is less, everybody. If it is lesser than 10 centimeter, if you can bring it very near to you, everybody, which is seldom not possible, that means you have extra strength in your extraocular muscles. So this is a simple way we can measure the vergence power, everybody. Done. So group 4, measurement of ocular deviation, has a number of tests, as you can see on the screen, guys. We can divide these tests into two groups: objective tests or subjective tests. I hope you understand the difference between the two basic words, objective and subjective, guys. Objective means in which the object, everybody, is seeing the results of the test. Okay. So between a patient and a doctor, the doctor is the object and the patient is the subject, everybody. So in objective test, patient does not have any role in terms of the participation in the test, in terms of answering in a test, everybody. But subjective test means which solely rely on the answers of the patient, everybody. So we are asking the patient a lot of information while doing the test. Those are subjective tests. Objective tests which do not involve any input from the patient per se. Are we clear about this? Now, objective tests, there are 4 important tests that we will discuss in detail. Number 1, Hirschberg test. Number 2, Bruckner's test. Number 3, cover uncover. And number 4, prism bar cover. A very important battery of tests in our examination of squint. Subjective tests can be based on 2 principles as listed on your screen. The diplopia principle. That means these tests induce dissociation of images leading to diplopia, and hence we are able to test whether the patient has squint or not. If the patient has squint, diplopia will become a problem. Otherwise, it will not become a problem because I will be able to still fuse all the images. Or on the haploscopic principle. Here I will be discussing just 2 important tests with you which are done commonly, the Maddox rod test and the Maddox wing test, guys. Okay. So let's start in detailed discussion of the 6 tests that we are going to discuss under measurement of ocular deviation. Let's start with our first test, everybody. Hirschberg's test, or as you can see the name written, Hirschberg's corneal reflection test. Okay, everybody. So I've written corneal reflection under brackets to make you understand on what basis are we doing this test. Okay, corneal reflection. So what do we understand by corneal reflection? Let me ask you again, what is the color of the cornea, everybody? My cornea looks black, but it is transparent. Yes, guys. Okay. So my cornea is transparent, or if I talk in simple basic language, I can say my cornea is like a glass. शीशे जैसा है. Yes. So whenever you shine light on a glass, everybody, we know that light reflects back. A point of reflection is formed. Yes. Similarly, if I throw light onto my cornea or your corneas will shine with a reflection of light as seen in the image on the screen. Can you see, everybody, in the center, in here, everybody, a reflection of light seen on the cornea? Yes. So that means this test we are discussing is based on this reflection of light. Let's see how. So corneal reflection test, everybody, can have 2 uses. The first use is it can be used to tell the direction of deviation. The second use, it can be used to calculate the degree of deviation. So we are trying to solve 2 questions through this test. Let's first see how do we understand the direction of deviation through Hirschberg's test. Let's see this image to understand our test. Everybody, in this test, the right eye is looking straight and normal. the left eye is deviated inwards. Okay. Now, let's first see the right eye, everybody. In the right eye, I am drawing a landmark through red color. All of you can see, I hope. Yes. What is this landmark, everybody? Corneoscleral junction, or I can say limbus. Then I am drawing this landmark through green color, everybody. What is this landmark? What is this landmark? Yes, everybody, pupillary margin. Now, if I carefully see where is my corneal reflection, I can draw this line to understand. Yes, this is right in the center, everybody. Can I say? So, I say my normal corneal reflection is in the center of pupil. Okay. Now, let's see the left eye, everybody, to understand. In left eye, again, I will draw this landmark first of all. I am drawing through red color the corneoscleral junction on the limbus. Then I am drawing through green color, everybody. Again, this is my pupillary margin. And through blue color, I draw a line through the center of the pupil. Now, it is very clear to me that in the left eye, the corneal reflection is not in the center of the pupil. Right, guys? Yes. Where is it, everybody? It is somewhere, I can say, outside the center of the pupil. Am I clear to everybody? So, the corneal reflection is temporal to center. Can I say, everybody? The reflection is outside, but the deviation is inside. So what does it tell us? When the eye deviates inwards, the reflection basically is visible outwards. So can I say, everybody, the direction of deviation, which is inwards, is opposite of the direction of corneal reflection. Are you getting the fundamental here, everybody? This is a case of large angle squint, so you can easily see the eyeball getting deviated inwards. But in small cases, when you can't see through your naked eye, you have to rely on the position of the corneal reflection. And the rule for corneal reflection, again, I will say is, everybody, deviation opposite of reflection. Let me write it out for you to be able to remember this, everybody. Through a mnemonic, the mnemonic becomes DOOR, D-O-O-R. What is the mnemonic, everybody? The deviation is O for opposite, O for off, R for reflection. Okay? The normal corneal reflection should be seen in the center of the pupil. We see the direction of the deviation based on the direction of the reflection. If I can enumerate it for you, all of you, I will say, everybody, normal corneal reflection is equal to center of pupil. Okay? If corneal reflection temporal to center, then what is the answer? Temporal means outside, so deviation is inside. Very good. ESO. If corneal reflection is nasal to center. Guys, I can't spoon feed more than this. I've shown you the image. I've told you the mnemonic. Now I am guessing that you are answering along with me, guys. All of you should be on the same speed, same page with me. Corneal reflection, nasal to center. Nasal to center means instead of center of pupil, it is nasal. Nasal means inside. That means the deviation has to be outwards. And outward means what, everybody? Exo. Yes? Or I can say corneal reflection above the center. See, now we are not talking about inside or outside. I am talking above the center. Okay, vertically above. If it is above, that means the eyeball, it has to move in opposite direction. That means the eyeball has gone down, everybody. Down means which deviation? Hypodeviation. Or lastly, I can say corneal reflection. Yes, below the center. And if it is below the center, that means the reflection has gone down. So the eyeball has gone up, and upward deviation means what, everybody? Hyperdeviation. Okay. So I've tried to explain through 3 points. Number 1, the image. Number 2, the mnemonic. And number 3, writing out the whole thing. I don't think you should have any confusion, anybody here. Right, guys? Right. Okay. So now let's move on to the second use of Hirschberg's test, which we said is to measure the degree of deviation. How do we measure the degree of the deviation? So we have a formula. 1 millimeter deviation of corneal reflection from center of pupil. Okay, we are measuring the distance. I hope we are pretty clear here. 1 mm deviation of corneal reflection from the center of pupil is equal to 7-degree squint. So the patient is standing in front of you. You take a scale, you keep the 0 mark on the center of the pupil, you measure the distance of deviation. Then you apply the formula 1 mm is equal to 7 degrees, or everybody, there is another unit of measurement, 14 prism diopter squint. So now the formula becomes 1 mm is equal to 7 degrees or 1 mm is equal to 14 prism diopters. Am I making myself very clear here, everybody? There should be no confusion in this. Okay. Examiners ask anything, everybody. Examiners also ask, based on this mathematics that you know, 1 prism diopter, I am writing short form, is equal to how many degree? Do you understand the question? They didn't ask you about squint, they ask you about mathematics, everybody. Because they know now that you know 1 mm is equal to 7 degree or 14 prism diopter. They want you to know mathematics. 7 prism diopter is equal, 7 degree is equal to 14 prism diopter. So 1 prism diopter is equal to half degree, everybody. They can ask you anything, everybody. It's important to absorb the knowledge, and then the knowledge can be asked in any way whichsoever, everybody. Yes? So the idea that we know the MCQs is wrong. You don't know the MCQs. You have knowledge, and based on that you solve the MCQs, guys. Right? Now, you know this formula. If the patient is standing in front of you, actually you are examining in the OPD, you can keep a scale. But let's say you were not there in the OPD, but you have a photograph of the patient. Now, based on that photograph, somebody is asking you what is the degree of the deviation. So how do we calculate that? See, if I enlarge the photograph, the degree of deviation should become larger because your scale is fixed distance. So either you know the scale of enlargement of the image, you know all that computer graphic thing, right? Or you use smartness. So what is the smartness, everybody? The smartness says, again I will go back to the image, that there were 2 landmarks. The first landmark was limbus, the second landmark was pupillary margin. So there should be some use of these landmarks. So we say, in an image, degree of deviation number 1, if corneal reflection at limbus 45 degree. Number 2, if corneal reflection at pupillary margin, this is equal to 15 degrees. Are we clear about this, everybody? There should be no confusion about this. Yes? So there were 2 landmarks. Again, I will show you, everybody. 45 degree limbus, 15 degree pupillary margin. Okay? I'm again and again repeating so that it gets fixed in your mind. Now, I am showing you this photograph. I am asking you, tell me the degree of deviation in the left eye. Can all of you tell me the degree of the deviation? The answer is written right on your screen, everybody. In the left eye, the corneal reflection is shining brightly at which point? At limbus or pupillary margin? At pupillary margin, yes. So that means left eye is a case of 15 degree ESO. Can I say, everybody, that left eye is a case of 15 degree ESO based on the image, based on the basic rule that we know. I hope we understand. To recapitulate everything, everybody, I can show you this graphic, everybody. Normally, number 1 at the center of the pupil. All of you can see center of the pupil. Yes, number 1 image. Then if it is at the pupillary margin, 15 degrees. Or if we use math, 30 prism diopter. Image number 2 is, everybody, 15 degree, 15 degree. ESO and EXO. Then image number 3. This is important. Neither at the pupillary margin nor at the limbus. Somewhere in between. Somewhere in between is 30 degree. I hope you understand this. See, everybody, this is my pupillary margin. This is my limbus. But now the line is neither at the pupillary margin nor at the limbus. See here also, this is my pupillary margin, this is my limbus, but this is somewhere in between, so it is 30 degrees. Or if it is at point number 4, it is at limbus, limbus is 45 degree or 90 prism diopter, as you can see in this image. Add the limbus, everybody. Okay, so all the possible images of the degree of deviation in this graphic solved for you. Done. That is in entirety all questions answerable, everybody. The test number 1, Hirschberg's corneal reflection test. Now, image based questions, I hope you understand, but let's say what kind of a theoretical question can be asked to you. So if I ask you an MCQ, a patient on examination has, everybody, corneal reflection visible below the center of pupil at limbus. What is your diagnosis? Simple theoretical question. 2 answers here, everybody. At limbus. At limbus should tell you 45 degree. Below the center of the pupil. That means the reflection is below. That means the deviation is up. Deviation up means hypertropia. 45 degree hypertropia. Okay. So the 2 uses combined in a theoretical question and asked to you. I hope there is no confusion about this. Yes, guys, everybody clear about this? Okay. Now, let's move on to the second test in the list, everybody. The second test is Bruckner's test, everybody. Yes, I hope you remember the list, everybody. So this is the list. We have done Hirschberg's test. Now we move on to Bruckner's test, everybody. So, Bruckner's test is used for screening of squint in infants. So the word which is important is screening and in infants. Okay. So infants are basically not going to help us in doing any test, everybody. They are going to keep on constantly moving the eyes. They don't follow the direction. So we are screening. We are trying to find out basically whether the eyes are normal or abnormal. Okay. Now, how do we do it, everybody? Method. So the method is we use a direct ophthalmoscope. To elicit the fundal red reflex. Basically, whenever we shine light into the eye, we see a red eye, everybody. That is the fundus red reflex. That has been explained to you in the retina chapter, everybody. Yes, direct ophthalmoscope to elicit the red reflex and then compare brightness and intensity in both eyes. Okay. Now, let's see, everybody. 3 images through which we understand this test. Image number 1, image number 2, image number 3. In the first image, everybody, I can say equal brightness and color in both eyes. Yes or no? Yes. That means both the eyes are normal. No confusion, I hope. Now, if I see the second image, in the second image, what do I see? I see some kind of crescent of light color. Yes or no, everybody? So, crescent of different color intensities. If you see such crescents, everybody, then the diagnosis becomes refractory error. Okay. And lastly, everybody, if you see this image, what do you see, everybody? That the right eye is darker and the left eye is brighter. So I can say difference in brightness. Yes. In such a case, what is our diagnosis? Darker eye is normal. That means the other eye has squint. Am I making myself very clear here, everybody? Yes. So just based on a torchlight examination in an infant, I will be able to ascertain whether the eyes are normal or whether they have refractory error or they have some kind of a squint, everybody. Yes. So in this, we can see the left eye is brighter, the right eye is darker, and that means we have a case of squint with us. No confusion, I hope, everybody. And this is your simple Bruckner's test. Moving on to the third test in the list, everybody. Cover uncover test. Again, going back, everybody, we have covered Hirschberg's, we have covered Bruckner's. Now moving on to cover uncover test. Now, cover uncover test, even though the name is one, cover uncover, it is actually two parts. Cover test is different, uncover test is different. Cover test, everybody, this is used to confirm tropia. Please focus on the English here. I am saying it is used to confirm tropia. See, tropia is manifest deviation. That means deviation which is already visible. So when the deviation is already visible, I don't need to diagnose it per se. I am just confirming that yes, it is a case of tropia and I am not mistaking it for squint. That means it is not a case of pseudostrabismus basically. It is an actual squint. It is a true deviation, not an apparent deviation. I am just confirming the diagnosis. Okay. But uncover test is used to diagnose phoria. Again, see the word here, everybody. Now it is diagnosed because phoria is hidden deviation. So if a patient comes to you with that story, everybody, a child who says, I love to study, then I go out to play football, first my eyeballs become deviated, then they become normal. I hope you remember phoria, everybody. Yes. So the child has come to you and there is no deviation. Then how do you diagnose? Just based on history? No. You need to do a test, and that test is, everybody, uncover test. Okay. So to remember, everybody, if you need mnemonics, everybody, I can say CT scan. Cover test is used for tropia. Or I can say, everybody, up. Uncover test is used for phoria. Okay. If you love mnemonics. Then, everybody, I will give you another mnemonic. Yes, 3 mnemonics. First mnemonic, second mnemonic, third mnemonic. Whenever I do cover or uncover test, which I will explain to you in detail in just a while, I see some ocular movement. And then based on that, I form a mnemonic. DOOM. D-O-O-M. Deviation is opposite of the movement seen. Wherever you see the eyeball moving, the deviation is always opposite to that movement. Okay. 3 mnemonics I'm using. Cover test, tropia, CT, uncover test, phoria, UP, DOOM, deviation opposite of movement. Now, based on these 3 simple mnemonics, everybody, let me ask you MCQs and let me tell you how simple MCQs can be made from cover uncover test and can be answered easily. Okay. On right eye cover test, left eye is seen to move inwards. Okay. This is what is written in your question. That you have done a right eye cover test and you see that the left eye is moving inward. What is your diagnosis? So I see, first of all, we are talking about cover test. If I am talking about cover test, I must be talking about tropia. So I see the option which is listing tropia. Then I see that the left eye is seen to move inwards. I think about the mnemonic DOOM, deviation is opposite of movement. The movement is occurring inwards. That means the deviation should be outwards. Exotropia. And then I see which eye is moving, left eye or right eye? Left eye. So my diagnosis is left eye exotropia. Are we clear about this, everybody? How to solve this question? Just based on the 3 mnemonics. Cover test, tropia, direction of movement opposite, and which eye is moving? Left eye. So left eye exotropia. Okay. Let's see if you can answer another question, everybody. MCQ number 2. On right eye uncover test, right eye is seen to move outwards. What is your diagnosis? Okay. Let's take 15 seconds. Let's try to answer this. I know the answer is very simple. I know all of you know the answers. Let's just try to calculate it. These are the kind of MCQs that will come, everybody. Let's try to answer this question. Okay. Okay. I know you have seen the first word, uncover test. Yes. Uncover test means Fourier. Okay. First job solved. Now let's move on to the second word, the direction of deviation. Direction of deviation. The eye is seen to move outwards. So if the eye is moving outwards, the direction should be opposite. Eye moving outward, that means the deviation was inward. Yes, remember, deviation opposite of movement, and inward means ESO. Which eye is moving? Right eye is seen to move. So that means which eye has squint? Right eye. The answer is right eye ESO Fourier. I hope you have been able to do this. These are the kind of cover and cover test MCQs which students find difficult. They are not difficult. Even without explaining you the cover and cover test, I can help you solve the MCQs. But is it important to understand the cover and cover test? Absolutely, everybody, it is important. You should do the cover and cover test in a patient of squint in your postings, whether you are doing in your internship or whether you are in third year. It is important that you find time to do this. It is a very important concept. If not everybody, then I am going to show you some images, and through that we are trying to solve or help you solve cover and cover test. Let's see this image. Image number 1 again here, everybody. Okay. In image 1, part A, everybody, what do we see? We see that the right eye is looking straight, but the left eye is deviated outwards. Yes, the answer is already written for you, that on presentation, it is visible to you that it is a case of left eye exotropia. That means you need to do which test, everybody? Cover test. Why do you need to do cover test? You want to confirm. You want to confirm that it is actually a tropia. It is not a pseudotropia. It is not a pseudostrabismus. Okay. So in cover test, we cover which eye? We cover the normal eye. Okay. So see, the cover is always opaque, everybody. So I have covered the normal eye. As soon as I cover the normal eye, what do I see? In image B, everybody, I see that the left eye, which was deviated outward, is starting to move in. As soon as I cover the normal eye, the left eye moves in. Okay, this I can see in the image. I'm just writing what I can see in the image. But the question is why, everybody? Let's try to understand the fundamentals here. Before I did the cover test, the right eye was looking straight at the object, but the left eye was deviated outwards. Only one eye was looking at the object, that is the right eye. Okay. Now I close my right eye. As soon as I close my right eye, no eye is looking at the object. So the brain tells the left eye, now you are the only uncovered eye, you are the only eye which can see. So please make a movement to fixate at the object. So the object was straight ahead. Left eye was deviated outward. So the left eye had to make a corrective movement inwards, everybody. So the left eye makes a corrective movement inwards and then looks at the object. Are you clear why this movement occurs? Yes, because I closed the normal eye, so to fixate at the object, the left eye had to move inwards. And what is the mnemonic we explained, everybody? The direction of deviation is opposite of movement. The direction of deviation was exo, and the movement we saw was inwards. Am I making myself very clear here, everybody? Yes. Now, in image C, as soon as we uncover here, everybody, again we see that the left eye moves outwards into its position of deviation. I hope we are clear about this, everybody. We have been able to confirm that it is a case of tropia. No confusion, very simple image. I don't think such an image will be asked to you. If an image is asked, it will be the next set of image that will be asked. Let's see this, everybody. Image 2, part A. In part A, what do I see? The right eye is looking straight and the left eye is also looking straight. Both the eyeballs are looking straight. On presentation, both eyes look normal. No deviation. That means either it can be a normal eye or it can be a case of Fourier. Yes or no? What am I interested in? I am interested in the fact that if it is Fourier. Why do I think it is Fourier, everybody? Because the patient is giving such a history that sometimes my eyeballs deviate, sometimes, remember everybody, under conditions of ocular stress. So I say, let us do uncover test. But sir, to uncover something, I have to cover something first. Understand? If I have to remove something, I have to put on something first. So in image B, what do I see? Again, see, though something is visible behind the cover in the images, I am covering that eye and I'm not explaining anything to you because you can't see. If I cover my right eye, I can't see anything. Okay. So the patient had given history in the right eye. So I cover the right eye. When I cover the right eye, there is no movement. Should I be alarmed? No, I should not be. Why? Everybody remember tropia. When I covered the normal eye in tropia, the deviated eye moved to pick up fixation. But in this case, everybody, both the eyes are already looking at the object. Because both the eyes are already looking at the object, whether I cover the right eye or I cover the left eye, because the other eye is already looking at the object, there will be no movement. So cover test becomes useless. But after I've done the cover test, I do the uncover test. I uncover the right eye. When I uncover the right eye, I see some magic happening. What do I see? That as soon as I uncover the right eye, everybody is seen to move in this case. The right eye on uncovering moves inwards. What does it tell us? It tells us that when I had covered the eye, the right eye must have moved outwards. So when I'm uncovering, the right eye is making a corrective action inwards. You don't understand? Let's try to understand. The patient is a case of phoria. Both the eyeballs are looking straight. This fusion is maintained by the extravergence power in the extraocular muscle that we have just read. Yes? Now as soon as I cover the right eye, I break the fusion. Yes? Now the right eye is free to act on its own. The left eye is free to act on its own. So the right eye says, I will go in the position of my maximum comfort. Okay. So the right eye behind the cover is deviating into its normal position where muscles do not have to act extra to keep fusion, which was exo. Okay, everybody. So as soon as I covered the right eye deviated out. But it is not visible to you because your right eye is covered. As soon as you uncovered, the right eye said, oh, now I have to maintain fusion again. So to maintain fusion, the right eye, which was in its comfortable position exo, is making a corrective action inwards. Okay, everybody? So the eye on uncover is seen to move inwards because it had moved outwards. Again, following our mnemonic, direction of deviation exo is opposite to the direction of movement, which is inwards. Am I making myself very clear? So that means in this case, what is my diagnosis, everybody? Right eye exophoria. I hope I am very clear. Which test am I doing here? Uncover test. Phoria. On phoria, it is moving inwards. Everybody, on uncover, it is moving inwards. That means the direction is exo. Right eye exophoria. So such an image can come to you. Please see carefully, everybody. If such an image comes, focus on the first image, everybody. Both the eyeballs will look normal. Then focus on the uncover part, everybody. Uncover part. In uncover part, such an arrow will show you the direction of movement, and then remember that the direction of movement is opposite to the direction of deviation. Absolutely same, absolutely simple. If you are studying it for the first time, just wrap your hands around it. It is an absolutely simple thing to understand. If you do it in a patient once, and if you see it in a patient once, you will never forget it. And that is the beauty of concepts, everybody. Conceptual things you don't forget, factual things you forget. So you have to do rectification. Squint is conceptual. Squint, once you understand, once you get it into your top level, everybody, you don't take it out from there, everybody. Done? That's all about cover and cover test. Now we will move on to our fourth test, which we are left with is prism bar cover test. So prism bar cover test, guys, or PBCT, as is clear from the name, we are covering the eye with a prism and then we are performing the cover test, alternate cover test. Once we cover the right eye, once we cover the left eye. Okay. More details later. First of all, let's learn a very important MCQ. This is the best test to measure the degree of tropia. This is the best test to measure the degree of tropia. We could also measure the degree of tropia through Hirschberg's reflection test. But as we understood just now, everybody, a little while back, that test was not very accurate. We were estimating. Even when we are measuring with a scale in a live patient, everybody standing in front of us, we are not sure whether it is 0.9 mm or 0.95 mm or 1 mm. I hope you understand, right? So there's a lot of guesstimate work in Hirschberg's reflex test. But in prism bar cover test, we can measure the accurate degree. Now, why? I hope the bell rings into your ear. We know that the degree of deviation can also be measured as prism diopter. So we actually know that prisms can neutralize squint. So that is the word. What is the principle of this test, everybody? The principle is neutralization. Based on the property of light that when it passes through a prism, it always deviates towards the apex. We are trying to neutralize squint. How are we doing this test, everybody? Let's see the image. Can you see the prism bars, everybody, here? Yes. Prism bar basically means like a scale, but increasing power of prism. So starting with the least power of prism, you can see thicker prisms, everybody. That means the power of prisms is increasing. Same in this, everybody. Yes. We keep the prism bar in front of one eye, as you see in this. Then we perform cover test, uncover test, cover test, uncover test to see whether any of the eyeball is moving. At the point of neutralization means when the prism I place in front of my eye is equal and opposite to the power of my deviation, everybody. At that point of time, cover uncover test, the eyeball will stop to move. Do you understand what I'm trying to say? Yes? Now, the only question which comes into the mind is, if this is my prism, everybody, prism is apex and prism is base. I can keep the prism in this direction. I can keep the prism in this direction or this direction or this direction. Okay. So what should be the orientation of my prism to be able to neutralize a specific deviation? Okay. So please remember, everybody, the mnemonic DOOB. Deviation is opposite of base of prism. Okay. Now we have formed such a mnemonic so that we continue with the trend of our DOOR, DOOM and DOOB, door, doom, doob. So it becomes easier to remember. Obviously, this is because of a lot of optical movements. We can't go into the details in this lecture here, everybody. If you are interested, I would really like that you open your textbooks of optics. If you open your textbooks of optics of the 11th or 12th class, or a lot of books in our third year also give that, and you study that in detail. For here, everybody, if you use this mnemonic, you understand that if it is a case of ESO means deviation inwards. So my base should be out. I will use what kind of a prism, everybody, to neutralize? Base out prism. If it is a case of XO, I will use base in prism. XO means deviation out. So prism base should be in. Similarly, if I can complete the list, hyper means up. So base should be down. And hypo means deviation downward. So base should be upwards. So I hope you understand these bases. Apart from the image direct based questions, this is the kind of question that can be asked as an MCQ to us. Prism bar cover test. Now, if we go back to the list, everybody, these are all the objective tests done. Okay, image, theory, everything. Now we need to study Maddox rod and Maddox wing test, which are subjective tests. So we have to depend a lot on the responses given by the patient. So let's see, everybody, Maddox rod first. As soon as you see the image on the screen, I hope again you remember something. Students who have passed out their third firsts, everybody. This is an instrument which is usually kept in all the instrument identification vivas. You know, there is a tray with a lot of instruments. Then the external will come and say, pick any instrument. You will pick up this red looking instrument, but you don't know anything about it. But at least I hope now you know that this is called as Maddox rod. So to remember, I say it is a red color striated lens. Okay. plano-convex lens. Yes, it is not a plane lens, it is a plano-convex. Plane, convex, plane, convex, plane, convex. Striated lens, like rods in it, everybody. Maddox rod. Okay. Now, what are the uses of Maddox rod test? First of all, number one, it is used to measure degree of phoria. See, that is the important word here. The degree of phoria at far fixation. See, in every test in ophthalmology, you have to give the patient a target. Now, the target can be a near object or a far object. Okay. So, Maddox rod test, if done accurately or done well, the patient has to be looking at a far point of fixation. Now, secondly, it can be used as a macular function test. And lastly, a variation of this test, double Maddox rod test. Okay, double Maddox rod means instead of keeping Maddox rod over one eye, we keep Maddox rod over both the eyes. Okay, it is used to test for cyclotropia. I hope you remember in cyclodeviation and X cyclodeviation. Again, saying that theoretically they are present, you cannot see them clinically. But if it is a case which involves some in cyclodeviation and X cyclodeviation, and we want to test out what is the degree of in cyclodeviation or X cyclodeviation, then we have to use double Maddox rod test. We usually don't need it, but obviously we have such a test in our battery of tests. Okay. Now, use is done, image done. But how do we actually perform this test? What is the method of Maddox rod testing? This is one of the topics which students who do not read, they keep on getting confused, keep on asking doubts day in and day out. So I hope if you are watching this video, everybody, you put your mind into it and you try to understand it. It's very easy to understand. It's just that we have never understood it. We've never tried to understand it. Right, guys? Okay. So let's see, everybody. Let's see this photograph. In this photograph, what do we see? In this photograph, we see right eye is uncovered, but the left eye is covered by a Maddox rod. This is what the examiner is looking at when he is looking at the patient. Now, for the same patient, what is the patient seeing? So, this is the examiner's view. For the same patient, this is the patient's view. Okay? Now, everything is reversed. I am looking at the patient, but you are the patient, so things reverse. Now, this is your left eye, this is your right eye. Left eye, right eye. I hope you understand. But when I am looking at the patient, this is the right eye, this is the left eye. Okay? Clear? I hope. Wrap your head around it, everybody. Right eye, left eye when you're looking at the patient. But when you're talking about yourself, you are the patient, left eye, right eye. Okay. So, there is a Maddox rod in front of the left eye. Can you see? What is the Maddox rod doing, everybody? Because of striations into it, it is converting a point source of light into a streak. Okay. So now, if the patient closes the right eye, in front of the left eye, because the patient has a Maddox rod, what is the patient seeing from the left side? He's seeing a red colored streak. If the patient closes the left eye, there is no Maddox rod. So the patient is seeing a point source of light from the right eye, which I've shown through a dot. I hope you understand what is the patient's view. Okay. Now everything will depend upon fusion. Okay. So after we have placed a Maddox rod over the left eye streak should be visible, right eye dot should be visible. Now we ask the patient what is visible to the patient. So what are the results? The first patient says, first patient A, that I see a red streak and in the middle of that I see a yellow point source of light. What does this mean? This means that the image from the left eye, the streak, and the image from the right eye, they are fusing with each other. Fusing with each other, that means the patient's eyes are normal, or I can say ortho. Just like ESO and EXO, if normal position of eyes, like my eyes, I will call them ortho. Okay. Second patient. The second patient says, sir, I can see two different images. I can see a red streak on the left side. Again, understand this is the patient's view, everybody. So this is the left side. I hope you understand this is the left side. There is no confusion about this. I will rub this line now. Okay. So the left side I can see a red streak and on the right side I can see a dot. That means the images are not fusing. If the images are not fusing, it means there is diplopia. And we call this which kind of diplopia? Uncrossed diplopia. Uncrossed because there are two images, but the image which should have been seen from the left eye is visible on the left side. The image which should have been seen from the right eye is visible on the right side. Are we clear about this? Uncrossed diplopia occurs in cases of ESO deviation. So when the patient reports such a thing, we say the patient is suffering from esophoria. We are talking about phoria, Maddox rod, everybody, yes? Third patient. Third patient also says, sir, I see two different images. But the patient says from the left side I see a dot, whereas from the right side I see a streak. Now what has occurred? Two different images. That means everybody diplopia. But the images have crossed each other. The streak which should have been visible on the left side is visible on the right side. The dot which should have been visible on the right side is visible on the left side. That means now I have which diplopia, everybody? I have crossed diplopia. And crossed diplopia is seen in cases of exo. Crossed diplopia is seen in cases of exo. I hope we are clear here about this, everybody. The left and the right, everybody. So in the exam, this image is given to you and you are asked the diagnosis. You just need to remember that this is the examiner's view. So in the examiner's view, it is on the left side. But for the patient's view, this side becomes the right side. If you understand this fundamental, you should not have any problem. Along with that, please remember uncrossed ESO, crossed EXO. A very simple trick to remember I can say is, if I write EXO, it is EXO. Can I write like this? Can I say X is equal to cross? Okay. So very simple way to learn that X means cross. So EXO will have crossed diplopia and ESO will have uncrossed diplopia. Am I making myself very clear here, everybody? Yes. And that's all about my simple test, Maddox rod test. This is frequently asked, can be frequently asked in your Vivas as well as in your MCQs, whether you will be appearing for NEET or next, everybody, because this is a easy test and this is the test which we usually perform during our postings in a evaluation of patient of squint, everybody. Yes. Now, there is another test, everybody, similar to it, which we had named, which is called Maddox wing test. This is an obsolete test. Nobody does it anymore. But if I ask the question, you should remember that it is used to measure the degree of, again, phoria, everybody. But instead of far fixation, for this we have a near fixation. So that is the difference here, everybody. I am writing this line essentially to make you remember Maddox rod. I don't think Maddox wing will be asked to you, but Maddox rod will be asked to you. So please remember that the near fixation or far fixation point can be used in a question, because for near fixation phoria, Maddox wing is used, not Maddox rod, everybody. Okay. Now, this is the photo of this image, obsolete instrument, everybody. The patient uses this himself, holds it in his or her hand. Here, the patient will look from this. There is a target. The patient himself adjusts the target and we get to know the degree of the phoria, everybody. Again, obsolete. Nobody does it. Inaccurate test. Don't focus too much on it. Just remember the image if you can, everybody. Yes. This completes our list discussion of group number 4 tests, measurement of ocular deviation, in which we have studied in detail 6 important tests, everybody. I hope you have been able to understand this is the major battery of tests as far as measurement of deviation is concerned. Now, moving on, everybody, in the battery of tests or the examination of squint, we have another group number 5, I will say, everybody, tests for diplopia. Okay. Now, I'm saying I'm actually not testing for squint. I'm testing for a consequence of squint, that is diplopia. If you remember, there were 2 consequences of squint. One was diplopia and one was confusion. So we are basically saying if the patient has diplopia, that means there is some problem in ocular alignment. But if the patient does not have diplopia, then the eyes must be normal. So we are indirectly testing for squint. Okay. All these tests are basically based on dissociation, that they dissociate the images in both the eyes. The first test is red-green goggles. As is clear from the names, we will wear a goggle which will have a red color, which will have a green color. Red color in front of one eye, green color in front of another eye, such that both the images are separated or dissociated, and then we see the ability of fusion, right? Then second is known as Hess chart. This is a commonly done test. And the third test is known as Lee's screen. Okay. So let's focus on Hess chart. First of all, image. How does a Hess chart look like? Everybody. So this is what a Hess chart looks like. It is a printed piece of paper, everybody, which has a lot of squares drawn through red lines. But if we see, these are not straight squares. See, these could have been like this. Yes, but these are not like this. All the lines are concave. Okay. So this is what you need to remember when you are looking at such an image, that this image is indicative of Hess chart. The image-based question on this has never been asked. So the most likely first question that the examiners are asking you is to be able to identify this test. Okay, everybody? Now, once you know how to identify this test, even though a far-fetched question, but what do we actually do on Hess chart? Let us try to understand by this example. Okay. So this is a Hess charting. Okay. This is the patient's left eye. So left. This is the patient's right eye, right visual field. Okay. Now, if you see, there are some red dots marked. I hope you can see red dot, red dot, red dot. Okay. You can see these 4 red dots. These are telling the extent of the visual field basically, or the movement of the muscle through which you can look at such a point in such a direction. For the left eye, this is elevation in abduction, function of superior rectus. Elevation in adduction, function of inferior oblique. Depression in abduction, inferior rectus, and this is superior oblique. Okay. Now, we ask the patient to look in each direction and plot the point till which the patient is able to look. So you can see superior rectus, the patient is able to look comfortably till the point. Inferior rectus almost always comfortably. But superior oblique, there is a gross deficiency. Yes. So it is telling us that there is some problem in left superior oblique. Now, if there is a problem in a muscle, its antagonist overacts. So what is the antagonist of left superior oblique, left inferior oblique? We see that it has started to overact slightly. Also, what we see, due to the Herring's law of equal innervation of yoke muscles, the yoke muscle of the paralyzed muscle will overact. Because to be able to see in the direction, that is depression in adduction of the left eye, the superior oblique will be getting more and more impulse. But it is paralyzed, it is not able to act. Instead, it's yoke muscle which is also getting more and more impulse, which is left superior oblique, right inferior rectus. So focus, right inferior rectus. Right inferior rectus, the visual field or the movement has increased a lot, everybody. I hope you understand what I'm trying to say. So this test will help us diagnose diplopia in a particular direction. That is when looking towards the right side and down, and it will tell us the probable paralytic muscle. Okay, everybody. So that is how Hess chart helps us in diplopia charting and thus diagnosis of our case of squint. Am I making myself very clear? So you just need to see the movement, you need to see which muscle is paralyzed, and the antagonist in the same eye, and the yoke muscle, which is also called as a contralateral synergist, is overacting. Am I making myself very clear here? Yes, sir. Done. So this is all about Hess charting, in short, in sweet, and we move on. The next group of tests is tests for sensory anomalies. Now, what do we mean by tests for sensory anomalies? This is a group of tests which differentiates between 3 things. A, binocular single vision. B, ARC, which we have read a little while back, anomalous retinal correspondence. And C, suppression. If you remember, everybody, B and C, they were sensory adaptations. Yes or no? Do we remember? If not, I will quickly recap it for you. Anomalous retinal correspondence occurs as a sensory adaptation in case of small angle squint diplopia, that the corresponding points change. Yes, the fovea of the normal eye corresponds with the extrafoveal point of the slightly deviated eye to adapt for diplopia. And suppression was a sensory adaptation to confusion. In confusion, there were two different images we formed. So the brain will suppress everybody, the image coming from the deviated eye, everybody, which will lead to amblyopia. Yes. So we are trying to distinguish between binocular single vision, ARC, and suppression. In effect, we are trying to distinguish between a normal eye or a case of squint. I hope you understand. See, this battery of tests is examination of squint. We are directly or indirectly trying to figure out squint. Now, what are the tests we do in this group of tests for sensory anomalies? So the first test we do in this list is known as 6A I have written, Worth 4 dot test. Okay, everybody. In Worth 4 dot test, we show the patient a box of light or a screen which has 4 dots on it. Okay, as you can see in this image B, this is image A, let's say this is image B. Okay, now the first question that the examiner asks you is, what is the color of the 4 dots? So it is very easily visible in this. I will say 1 red, 2 green, and 1 white, or maybe slightly yellowish. Okay, 1 red, 2 green, and 1 white, I will say. That is the color of the 4 dots. As soon as you see this image, I hope this gets fixed into your mind. Now, what is the method of this test, everybody? So for the method of this test, see the first image. We ask the patient to wear red-green goggles. Now to make this test standardized, as a rule, red over right eye and green over left eye. Okay. Now, if the patient is wearing a red-green goggle, everybody, with red over right eye and green over left eye, what is going to occur? Very simple. The patient can see only red color from the right eye, and the patient can see only green color from the left eye. It is acting as a filter, everybody. Yes, as a sunglass. So if you wear a yellow colored sunglass, everything becomes yellow. Yes. So if you are wearing a dark, deep red, everybody filter, everything is red to you. Okay. Now, after this, the patient looks at the 4 dots. Patient looks at 4 dots, and then we have the results. So what are our results? Patient 1. Patient 1 is wearing red-green goggles, red over right, green over left, and the patient is looking at the 4 dots and saying, I can see all the 4 dots. I can see 1 red, 2 green, 1 white. That means what is occurring? Even after I have dissociated both the eyes, the images are getting fused in the brain. Yes. So I can see what should be seen. That means the patient has binocular single vision, or I can say the patient has harmonious anomalous retinal correspondence. That means the patient either has binocular single vision, or the patient had diplopia and ARC has become functional. So basically adaptation for diplopia has occurred, and now the patient does not suffer from any problem. Am I clear to you? Now, let's leave patient 2. Let's first understand patient 3, very easy to understand. Patient 3 is saying, sir, I can't see any red color. You are again and again asking me how many red dots, how many white dots. I can't see any red or I can't see any white dot. I can only see 3 green dots. I can only see 3 green dots. Why is that, sir? That must be because red color was from which eye? Red color was from right eye. The right eye must have been suppressed, everybody. There must have been large angle squint. There must have been confusion, and the adaptation suppression must have taken place of the right eye. Now, because the right eye has been suppressed, the patient does not see any red color. So the patient sees the normal 2 green, and the white dot also becomes green, because white dot can become any color, everybody. Yes. So this is trying to tell us the patient can only see the green color. That means the patient's only left eye is functional. That means the patient is suffering from right eye suppression. Am I making myself very clear? Now patient 4 is easier. The patient says, sir, again, don't ask me green light. I can't go. I can only stop. I can only see red colors. I can see 2 red dots. The red dot is red and the white also becomes red. The green are invisible because my left eye is suppressed. Yes, everybody. So patient 4 has left eye suppression. Am I clear to everybody? Done. No confusion in this. Now, what about patient number 2? Patient 2 says, sir, you told me that 4 dots will be visible. But I can see more, sir. That means my eyes are better. I can see actually 5 dots, sir. I can see through my left side 3 green dots and through my right side 2 red dots. That means what? Try and understand. Left eye functional, right eye functional, but they are not fusing with each other. That means the patient is still having diplopia. Okay? Or I can say non-harmonious ARC. That anomalous retinal correspondence, everybody, was trying to occur, but it has still not been able to take place, or even if it has taken place, it has not taken place properly. So the diplopia is still persisting. Left eye image, right eye image not fusing with each other. I hope we are clear about this. If we understood the consequences of squint and the adaptations of squint, as I explained you, then you will be using these concepts, and this is where you use these concepts. I hope Worth 4 dot test is very clear, everybody. You know the results and you know the images to answer this, everybody. Done? Now, moving on to the second test in this group of sensory anomaly tests, everybody. This test is known as Bagolini striated glasses. Again, as we understand from the name, we must be using some kind of striated glasses. But before we get to that, please remember this is the most physiological or the least dissociative test. Most physiological or least dissociative test. As we were trying to say in Worth 4 dot test, we are dissociating both the eyes. So here also we dissociate, but the dissociation amount of dissociation is very less. Okay. So we use striated glasses. As you can see in this image, you will be able to see some striations in both the eyes. Okay. 45-degree striations in one eye and 135-degree striations in the other eye. Okay. Now, as we shine light on these striations, the same fundamental takes place that was taking place in Maddox rod test. Lines will intersect the light and convert them into a 90-degree streak. So basically the patient will see a streak and another streak. Okay, everybody, from 45-degree, 135-degree streak, from 135-degree, 45-degree streak. Now, we ask the patient the results. So these are our results. Again, very easy to understand if you understood the Maddox rod test and also the Worth 4 dot test. If both the lines are intersecting with each other, that means the patient has binocular single vision or the patient has harmonious ARC. Yes or no? Both the lines are fusing with each other, intersecting with each other. Now, if you can only see one line, either you could see this line or maybe you could see this line, that would indicate some kind of suppression. Okay. Based on the 45-degree and 135-degree, you can see either right eye suppression or left eye suppression. If both the lines are visible but they do not intersect, that means it is a case of diplopia, ARC non-harmonious. But this gives you an extra added result of diagnosing central suppression scotoma, which is not diagnosed via Worth's 4 dot test. Both the lines will be visible, but in the center, everybody, the center part will be missing, which will be able to diagnose central scotoma for us. If you remember central scotoma, the diagnosis is or the causes were optic neuritis, toxic optic neuropathy and all such. Okay. Seldom used, but yes, this is one of the uses. Done. Now, what are the other tests in this group of tests of sensory anomalies? The third test is synoptophore. Again, a kind of an obsolete instrument. Nobody uses it. Another test called 4 prism diopter prism test. This is used in microtropia. Please remember this is used in microtropia. Microtropia is squint which is less than 5 prism diopters. And another test called as after image test. Again, nothing important about these tests to discuss in detail. Just remember the list of tests so that if it is asked which of the following tests are tests for sensory anomalies, blah, 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 you are able to answer the whole list. 2 important tests here, Worth 4 dot test and Bagolini striated glasses. So this covers our 6 important groups of tests for examination of a case of squint. And there is another accessory group number 7, which we will discuss or which we will learn about next. So the 7th, the last group of tests, guys, tests for stereopsis. Now, as we are well aware through our binocular single vision discussion, stereopsis is depth perception and a function of binocularity. Binocularity is achieved only when both the eyeballs are looking at the same object. If there is some kind of deviation, if you have squint, binocularity is lost. So the test for stereopsis will not be normal. So another way of testing for squint, indirectly. Okay. So what are the tests we can do, everybody? The first test is the two pencil test. This test for gross stereopsis. The test which is usually done is known as the Titmus fly test. All of you must have heard about the name. If you haven't heard about the name, if I show you the photograph, you will be able to recognize it. There is a big fly made out in it. Yes, you wear polarized glass. This is a vectorographic image, everybody, and you are able to see the fly in different angles, in different 3D postures, right, guys? And that is your Titmus fly test. But a better test than Titmus fly test is random dot stereogram tests. Now, they are better than Titmus fly test. But the question is why? As they eliminate monoocular clues to depth perception. Okay. So even though we say depth perception is a function of binocularity, but let's say we have a patient who has lost his one eye, still they can perceive a little bit of depth. There are something called as monoocular cues of depth perception. Random dot stereogram tests are better because they absolutely eliminate these monoocular clues and they only rely on the binocularity. Now, a question was previously asked a long time back on the clues of depth perception. So, giving you a table here, what are the depth perception clues during binocular vision and what are the depth perception clues during monoocular vision? During binocular vision, stereopsis, obviously we know, and then there is retinal disparity. But during monocular vision, there are a lot of clues, everybody, like motion parallax, overlay of contours and such. You can just remember the names of binocular and monocular. Just a once question which was asked may not never be asked again. Okay, done? Now, what are the names of the tests, everybody, that are random stereogram tests? So these are all the random dot stereogram tests. 4 tests in front of you, everybody. This test is known as Frisbee-Davis test. The second test, everybody, this is simply known as the Frisbee stereo test. The third test, which looks similar to the Titmus fly test, but instead of the fly, it has a lot of squares with stars in it. This is the TNO test. And the last test, everybody, in which you will be able to see a star, a cat, and a car made. This is known as the Lang test. So Frisbee-Davis test, Frisbee test, TNO test, and Lang test. These are the 4 random dot stereogram tests. Again, they are not done very commonly. If done, Titmus fly test is done. Please don't get into the details of this. That is my request to all of you. And that is all about our large battery of tests of examination of a case of squint. If we want to revise, let's revise. We start with the examination of ocular movements in all directions of gaze. And then because uncorrected hypermetropia can lead to esotropia, we go on to measuring the visual acuity, followed by measuring the fusional vergence, the excessive power, everybody, in which we saw there was a test called Royal Air Force ruler. Then we move on to the main group of tests, everybody, where we measure the ocular deviation. Through objective tests and subjective tests, 6 important tests you want to remember here. Hirschberg's corneal reflection test, Bruckner's test, prism bar cover test, cover-uncover test, Maddox rod test, and Maddox wing test. In all of these tests, if you want to form a basic line of understanding, it is opposite. The word is opposite. Deviation opposite of reflection, deviation opposite of base, deviation opposite of movement, everybody. Also remember that there are certain tests for diplopia, in which the most important is the test which is known as Hess chart. And then tests for sensory anomalies, which take into account anomalous retinal correspondence and the fact that suppression may or may not occur. Very easy to remember. 2 important tests: Worth 4 dot test, 1 red, 2 green, 1 white, and Bagolini striated glasses. And lastly, we end with A less important group of tests for stereopsis. So this is a very important part of Squint, everybody. This is the clinical part. Lots of questions get asked. I hope you have been able to understand and remember, and using all this information, we will be able to study our part 3 and part 4 of Squint. That will be the presentation of different types of squint. We start with paralytic squint.